Hello, we are going to talk about treating sleep disorders. It's a cute little slide. Thank God for my PMHNP. A couple of test questions you can take a look at, and here are some resource books that you could consider. So, assessing sleep disorders in the context of treating mental illness is very important. Um, So there are 8 categories of sleep disorders, and within there have been 85 sleep disorders identified. It's important to get a sleep-wake history, looking at the entire 24-hour cycle. So I will ask clients, how are you sleeping? Particularly on a first interview, I will ask them, do you have any trouble falling asleep? And if they say yes, I will want to know, well, how long does it take you to fall asleep? And then I will ask them if once they're asleep, do they stay asleep? And if they say they have awakenings, I will ask, well, how frequently? And after you've awakened, are you able to get back to sleep? And in addition, I would like to know, are they awakening too early and then can't go back to sleep? Do they have trouble waking up on time? And if they have problems with daytime sleepiness. So the client who tells you they're tired all the time, it's important to know what's happening with their sleep at night and also to find out if they're napping during the day and for how long. If you can talk to a parent, that's very useful, or the client's bed partner as well. And sleep diaries can be used. I believe there's a Fitbit that also records sleep quality or quantity. So some of the sleep disorders include parasomnia, such as sleepwalking at night, restless leg syndrome, periodic limb movement, hypersomnia, narcolepsy, along with the comorbid mental illness and or physical illness, such as chronic pain or other types of chronic illnesses. Very important to assess sleep apnea in your clients, because if they do have sleep apnea and you're treating them for depression, or if you're trying to help them sleep, you're going to really be having a difficult time and spinning your wheels if you do not consider the possibility of sleep apnea and send them to get treatment if you suspect it. The stop bang is a simple assessment that I've done, and I've often sent that over to the sleep clinic. So snoring, are they tired during the day? Tired on awakening, also headache on awakening is not unusual. Has apnea been observed? What's their blood pressure like? Their BMI, the age over 50 is significant, and also male, and neck circumference of 17 or greater, 17 inches. So like other mental illness we have studied, we would say there is an arousal spectrum of sleep and wakefulness. So it's really not completely black and white. It's not that just that you're awake or asleep. It's almost like being on a dimmer switch with different phases along the entire spectrum. And where on the spectrum you are is influenced by 5 key neurotransmitters. Those are histamine, dopamine, norepinephrine, serotonin, and acetylcholine. When there's a good balance between too much and too little arousal, one is awake and alert and able to function well. As the dial shifts to the right, there's too much arousal, and that can cause hypervigilance, insomnia at night, and if the arousal and sleeplessness continues to increase, that can cause cognitive dysfunction, panic, and in extreme cases, even hallucinations. So it becomes a vicious cycle if you don't treat the insomnia. There's a good chance that the depression or anxiety will begin or worsen, increase in weight, increase in inflammation, increased cytokines, increased depression and anxiety, and then that cycle repeats itself. Here we're looking at the sleep cycles. There are 5 stages. We call it sleep architecture. From stage 1, which is very light sleep, going into stage 2, which is a deeper sleep where the breathing and the heart rate slows, body temperature starts to cool. In stage 3, we have the deep sleep beginning, and the brain is generating the slow delta waves. And then stage 4, we're looking at very deep sleep. And finally, stage 5 includes REM sleep, rapid eye movement, where the brain waves speed up and the dreaming occurs. Some of our medicines decrease and or eliminate the REM sleep. So the neurobiology of sleep, we're talking about a few different anatomical areas. The first is the hypothalamus. Within the hypothalamus, we have the TMN, which is the tuberomammillary nucleus. This is the wake promoter. It gets you awake. And histamine is a player here. Then we have the ventrolateral preoptic nucleus. This is the VLPO. And so this is the sleep promoter, and the switch turns off. Melatonin is involved in this area. Next, we have orexin or hypocretin. This is involved in wakefulness. Orexin is a neurotransmitter, and it is critically involved in 2 of our newer medicines that are able to somehow turn the orexin off, which allows the person to go to sleep. And if you don't have the right amount of orexin, that may result in narcolepsy. We also have something called the suprachiasmatic nucleus. This has to do with our internal clock and management of the circadian rhythm, which is programmed by the light-dark cycle and melatonin. So different factors affect the circadian rhythm, but light is the most powerful synchronizer. So when light enters the eye, it is translated via the retinohypothalamic tract to the suprachiasmatic nucleus, which is within the hypothalamus. The suprachiasmatic nucleus then signals the pineal gland to turn off melatonin production. And so during darkness, there is no output from the RHT tract to the SCN within the hypothalamus. Then when darkness occurs, and there's the picture right there, when darkness occurs, so here we have the moon up, the darkness signals the pineal gland to produce the melatonin, which in turn acts on the SCN to reset the circadian rhythms. So keep in mind that depression in and of itself also alters the release of melatonin. It's possible that depression elevates levels of cortisol, and in turn, cortisol inhibits the production or the release of melatonin. There's a timeline on the left bottom of the slide. I'm not sure it makes a great deal of sense. It's trying to show phase delay problem with sleep. So one of the drugs we do not have in this country is agomelatine. Dr. Stahl does give a lot of attention to it, but we don't have it available because of potential liver damage. Agomelatine, FYI, is a melatonin agonist, and it may reset the circadian rhythm. Okay, so a little more about what is insomnia. So we're looking at excessive nighttime arousal. Insomnia is conceptualized as being related to hyperarousal at night. And so here the brain is in a red-orange color. So it is overactivated. So the agents that help to reduce the brain activation, for example, the PAMs, positive allosteric modulators of the GABA receptors, so benzos or Z drugs, also histamine 1 antagonists, serotonin 2A, 2C antagonists. All of those can shift the arousal state from being hyperactive to sleep. And now the brain is at rest. We also know that there is insufficient dopamine in the thalamus, so it doesn't efficiently filter, and so that can cause us to be distracted by things around us, and we describe this as having a foggy brain or excessive daytime sleepiness. So with excessive daytime sleepiness, we do not have enough arousal during the day. So we refer to this as daytime hyperarousal. Now we can try to help with that to increase the brain activation using either stimulants, modafinil, or even caffeine, and that can shift the state from being hypoactive to being awake and having a normal alertness. So the hypothalamus is a major control center for sleep and wake. The on switch, the wake promoter, is in the TMN, tuberomammillary nucleus, which is located within the hypothalamus. The off switch is in the VLPO, ventral lateral preoptic nucleus, VLPO. This is the area of sleep promotion. So the two primary neurotransmitters involved here are histamine from the TMN, which promotes wakefulness, and GABA from the VLPO, which promotes sleep. When the sleep switch is off, GABA is released from the VLPO, inhibiting the TMN, and vice versa. When the sleep-wake switch is on, wakefulness is promoted by the release of histamine. Okay, and we're looking at the diagram here of what's happening. So this is the wake promoter functioning. And this triggers the sleep promoter to be flipped on. and the cycle continues. So there are several processes that regulate sleep. The one major one, the circadian wake drive, is due to the input. So it could be light or melatonin or activity that's going to the SCN. And our sleep drive is homeostatic, and the homeostatic sleep drive increases the longer one is awake and decreases the longer we are asleep. So here we're seeing our blue slides with the transporter. In this case, we're looking at histamine and how histamine is produced. So the precursor to histamine is histidine. And the histidine is taken up into the nerve terminals via the transporter. And then there's an enzyme, HDC, histidine decarboxylase, that converts histidine into histamine. And then after it's synthesized, it's packaged into the synaptic vesicles and then stored there until it's released into the synapse. There it goes into the vesicles, and there it's being released. And then how is histamine action terminated? So histamine is broken down by two enzymes. It can be broken down by histamine N-methyltransferase, which converts histamine to N-methylhistamine. That is then broken down by MAO-B to an inactive substance, which is N-methylindoleacetic acid. So NMIAA. There you go. And the histamine becomes inactive. So we have actually H1, H2, and H3. H1 and H2 are postsynaptic. H3, however, is a presynaptic autoreceptor. We also know that histamine can bind to a glutamate receptor, referred to as NMDA, at an allosteric modulating site. So on the left, we see histamine binding to H1 and H2 receptors, which are postsynaptic, or binding to the H3 autoreceptor, or at the glutamate neuron, binding to an allosteric modulating site, which is NMDA receptor. So when histamine binds to postsynaptic histamine 1 receptors, in the process it activates a G protein linked second messenger system. Okay, so there's your G protein, second messenger system. That activates phosphatidylinositol and a transcription factor called CFOS. This results in alertness and wakefulness. Histamine 1 antagonists prevent the activation of this second messenger system and, in turn, cause sleepiness. So there's the H1 antagonist. It's interfering with the G protein linked second messenger system and stopping the activation of CFOS, and that results in sleepiness. We also know that histamine 2 receptors are not only in the brain, but they are also in the body. So when histamine binds to a postsynaptic H2 receptor, it activates the G protein-linked second messenger system with CAMP, phosphokinase, and a gene product called CREB. The actual function of H2 receptors in the brain is not completely understood. It seems to be, it does not seem to be directly linked to the wakefulness. Now, what about the H3 autoreceptor? When histamine binds to the presynaptic H3 autoreceptor, it stops further release of histamine. There are drugs that are an antagonist of these receptors that are being developed, which would in turn just inhibit or rather increase histamine release and thereby enhancing alertness and even cognition. Okay, this is showing us the histaminergic projections from the hypothalamus. You can see it's all over the brain. Okay, so we have some slides here that you may find interesting on treating insomnia. Okay, this is part 2 of treating sleep disorders. So we have a number of different psychopharmacology medicines that we can use to help with sleep. So benzodiazepines can help with sleep, and they are often used historically, and it will be likely that you will be referred patients who are using benzos to help them sleep. There are also the GABA PAMs, positive allosteric modulators. We would call these the Z drugs, such as Zolpidem, Zolpidem CR, or azopiclone or Zaloplan. We have melatonin agents, histamine agents, antidepressants used in low doses, such as trazodone or tricyclics or mirtazapine. The antipsychotic quetiapine can also be used to help with sleep. If you look in your Moodle folder, there is a Carlot medication report for use for treating insomnia. So we'll go over these. Okay, so the hypnotics come in different variations. So there are those with what we call ultra long half-life, so greater than 24 hours. So when that occurs, it can cause the drug to accumulate with chronic use. And when that happens, it can result in impairment, particularly increased risk of falls in the elderly. Some examples of these are Dalmane and Durrell. I don't believe either of them are still used or even available in the US. Then we have those hypnotics with moderate half-lives of 15 to 30 hours. Problem with these is that they may not wear off until the person needs to awaken. And so that can result in morning hangover effect. So there could be morning sedation and trouble with memory and remembering things. Some of the examples of this are Estazolam, which is Prosom, Temazepam, Restoril, most of the tricyclics, mirtazapine, and olanzapine. So there are those patients who, for whatever reason, I have found very difficult to get their insomnia under control. in which case these medications often can work really well. So I do have a few patients on temazepam who do not have morning sedation or hangover and did not respond to other medications with a shorter half-life, and so they're doing very well on this medication. And then we have hypnotics with ultra short half-lives, so 1 to 3 hours. These can wear off before the person needs to awaken and therefore not be a good choice to maintain sleep. Examples of these with short half-lives of 1 to 3 hours would be Halcyon, Sonata, Ambien, melatonin, and Rosarum. So if your patient's main issue is they just can't get to sleep, and especially if it's a temporary kind of a situation, they may benefit from one of these medicines given on a short-term basis. And also I've had patients who can fall asleep, but then they'll wake up a couple hours later and can't get back to sleep. And that's another example where I've used a drug with a short half-life and given them a handful of Sonata, for example, to help them get back to sleep. And the half-life is short enough that they aren't likely to have a problem on awakening with sedation. Then we have those that have short half-lives, but they're not ultra short. So their half-lives run about 6 hours, and they can provide a rapid onset of sleep with the blood levels staying at the right concentration to allow a person to get a normal night's sleep. So examples of these would be azopiclone, which is Lunesta. Notice that azopiclone has a longer half-life than the zolpidem. Therefore, it is often more effective than zolpidem to help people not only fall asleep, but also stay asleep. For some reason, zolpidem CR, Ambien CR, remains problematic to get approved, often requiring a PA. Other choices would be the low-dose trazodone, a low dose of doxepin. The low dose of doxepin is called Silanor, and it can be also very difficult to get this approved. And so oftentimes, if I am going to try low-dose doxepin, I'm more likely not to attempt the Silanor, but to give it in 10 to 25 milligram dosages. Low-dose quetiapine has also been shown beneficial, as well as low-dose diphenhydramine or Benadryl. Okay, so these are the 5 benzodiazepines approved in the U.S. for sleep, although I don't know for certain, but I think Delmain and Durell are no longer available. But look at the very long half-lives. And sometimes insurance can, even though these are generic, can give you some difficulty in getting them approved. So the benzohypnotics, just like when treating anxiety, the problem with the benzodiazepines is that it works for insomnia, but then it can cause problems because it works. In the short term, the benzohypnotics are effective to treat insomnia, but in the long term, they can cause tolerance and dependence, meaning the person will go through withdrawal and they may even stop working, but the person can't just up and stop it because they will have withdrawal symptoms. Okay, so here we're looking at a drug that affects GABA A function. Person has insomnia, they get the benzo, and it helps, they sleep. Eventually tolerance develops, the medicine is no longer working, but the person will have withdrawal if they try to stop it. And what happens is that they get rebound insomnia. So there are different opinions about the use of the Z drugs. Some people, some providers think they are a very poor choice and don't use them. Others do use them and even refill them year after year. I have had patients referred to me who were taking above the standard dose of zolpidem, so taking 20 milligrams. The maximum dose is 10 milligrams. But I had a few people come to me and their previous provider actually was refilling a 20 milligrams of zolpidem every night. And so I have worked with those patients to at least get them back down to 10 milligrams. But the problem that occurred was that it stopped working at 10 milligrams. And so when that happens, the solution is not to increase Ambien, the solution is to give them an alternative. Keep in mind though, if you're going to do that and you just stop the Ambien, they will have rebound insomnia no matter what else you give them. So I've had patients who said, oh yeah, my doctor gave me trazodone and it didn't work. And on further assessment found out that, yeah, they stopped the Ambien and then gave the person trazodone, and the trazodone wasn't enough to overcome the rebound insomnia from stopping the Ambien. So if you're going to do something like that, you actually have to do more of a cross taper and wean down the zolpidem very slowly, just like you would a benzo. And then slowly add the alternative medicine, or you're going to have rebound insomnia and nothing's going to work for this person. So it's rather challenging. So here we start with insomnia. The Z drug is given. Person sleeps. It works well. If it's stopped, you're going to get a rebound insomnia. So here we're looking at GABA A PAMs. So the positive allosteric modulators selective for the GABA A receptors that have the alpha subunit. And this first drug we do not have here. We do have Lunesta or azopiclone. We have Zaloplan, which is Sonata. We have Zolpidem, which is Ambien, and we have Zolpidem CR, which is Ambien CR. So it is pretty common to have insomnia occurring as part of depression and anxiety. We have found through the research that the remission of depression and anxiety may be improved when the person with depression, anxiety, and insomnia, if a hypnotic is added to go with the antidepressant. So then you end up with an improvement in insomnia as well as improvement in depression and anxiety. And so research findings show that when you combine an SSRI plus a Z drug, there's a 42% chance of remission, but with the SSRI alone, the chance of remission is only 33%. So melatonin or Ramelteon, the top two, the third one is not available here. They can produce sleep onset, but they don't work for sleep maintenance. Also, you want to caution people that melatonin isn't meant to be a sleeping agent. It's a hormone. We don't know a lot about long-term effects of using melatonin for sleep. I encourage people to start with a very low dose to help them fall asleep. It's not likely to help people stay asleep if that's their problem. And definitely not to exceed 10 milligrams. We also find that the effects on falling asleep may actually be better if we prescribe the melatonin in a very low dose, for example, 0.5 milligram, but given at supper time. We may find a better response, especially in adolescents who stay up later and later and later, and then, of course, can't get up at the time they need to, and they sleep later and later as well. So a low dose of melatonin at supper time, 0.5 milligrams, for example, might over time be helpful. So we have a newer medication. It's called Belsomra, and I don't have a slide for one that's even newer. That one is called Dayvigo, Dayvigo. Both of them work on orexin, and if you remember, orexin is the neurotransmitter that promotes wakefulness. What Belsomra and Dayvigo do basically is turn off the orexin neurotransmitter to allow the person to go to sleep. We find that it seems to work better when taken over time, and you have to let people know this is not a knockout drug. Sometimes Ambien is thought of as more of a knockout kind of a drug. Belsomra and Dayvigo work gently and slowly to help people fall asleep and gradually improve the length of time they're able to stay asleep. Okay, so here we're looking at the mechanism of action of diphenhydramine, which is Benadryl. Diphenhydramine is an H1 antagonist, which we see at the top right, but it also binds to muscarinic 1 receptors and therefore can have anticholinergic side effects. So should be avoided in the elderly population. So side effects would be things like blurred vision, constipation, urinary retention, memory problems, and dry mouth. Here we're looking at doxepin. Doxepin is a tricyclic antidepressant, and so in doses used to treat depression, it has a very high side effect profile because it works at adrenergic, H1, and M1 receptors antagonistically. However, at low doses, it is quite selective for the H1 receptor and so is effective on sleep. The actual hypnotic dose is 1 to 6 milligrams, but in some folks, I have been able to get a good effect on sleep at 10 milligrams. Okay, these two we're looking at are mirtazapine. The other one also not available here. Mirtazapine has effect on alpha-2 receptors, 5-HT3, and 5-HT2A and 2C. And so because of those effects, this will cause an increase in not only sedation and sleep, but also an increase in appetite. So mirtazapine can be an ideal choice for someone who is depressed, anxious, can't sleep, and can't eat, and have lost or are underweight. So trazodone is an interesting drug. As an antidepressant, we refer to it as a SARI, a serotonin antagonist at 5-HT2A and 2C, and a reuptake inhibitor. We see the CERT. So we're talking at doses of 150 to 600 milligrams. This is rarely used to treat depression. When trazodone is used as a hypnotic, we're looking at 25 to 150 milligrams. There, its effects on sleep are because of effects at alpha 1, H1, and 5-HT2A antagonistic activity. You see the reuptake inhibition is not going on at this dosage. So modafinil is a drug that helps with daytime sleepiness. We know it binds to the dopamine transporter. There it is. And it is believed that there's an increase in synaptic dopamine following the blockade of the dopamine transporter by the modafinil. That results in an increase in tonic firing downstream, and also results in effects on neurotransmitters such as histamine and orexin that can help with wakefulness. Okay, and we know that caffeine is often used to help people stay awake. It is because caffeine is an antagonist at the purine receptors, and particularly the adenosine receptors. The adenosine receptors are coupled with certain postsynaptic dopamine receptors and have a stimulatory effect. So when adenosine binds to its receptors, it causes reduced sensitivity to the dopamine receptors. So if you antagonize adenosine receptors by using caffeine, this prevents adenosine from binding there, thus increasing dopaminergic activities and in turn increasing wakefulness and probably cognitive action. So there's the adenosine binding. And there's the caffeine. And the person is able to stay awake better. So some things to consider when you are teaching your patient about sleep hygiene. So they need to prepare themselves to get ready for bed, just like we do for little children. They need to help themselves learn to relax before bed. Like so many of my patients go, and then fall into bed and think they're going to sleep, and then they don't, and their mind is racing because they haven't slowed themselves down and prepared themselves for bed. They're not taking care of themselves. So you need to teach them about sleep hygiene. Also, that when they take the medicine, be ready to get into bed. Don't go down and do a load of wash, because what happens, sometimes they bypass the period where the medicine is most effective at helping them fall asleep. They should also be careful for the first nights if they have to get up at night, in case it causes some effects on balance. We also know that perimenopausal women, due to hormonal changes, often have poor sleep quality because of disruptive sleep architecture, and they may need some treatment. Geriatric clients are more likely to have a phase advanced pattern. They may also have obstructive sleep apnea, restless leg syndrome, or even a dementia. And their metabolism of medications has been altered because of changes with their age. in pediatrics, you also need to know what's going on in their environment that they can't sleep. Adolescents are more likely to have a phase delayed pattern. Okay, and that concludes our lecture on treating insomnia.